So this slide actually reflects what I learned as I started my DM. And that was a time when I would make notes. The stress and the Benestent trial had just come in, and the stents had started to come in. So there were a lot of papers on how the restenosis occurs. And I still remember I made a note that two-thirds of the restenosis in a stent occurs because of recoil and negative remodeling, and one-third of it occurs because of neointimal hyperplasia. Come the bare metal stents, the recoil part was virtually taken away. So from the restenosis rates, which for a typical LAD would be 40 to 45%, fell down to about 15% or 15 to 20% because neointimal hyperplasia was not taken care of. Then came the drug-eluting stents, which intended to decrease the chances of neointimal hyperplasia. They did, but then they were associated themselves with a host of problems, and therefore we have the thought process of having biovascular scaffolds, and more importantly now, the drug-coated balloons. So this takes us through what I just said, plain old balloon angioplasty associated with a 35 to 40% restenosis overall, and in some vessels like LAD even higher. Bare metal stents decreased the restenosis rates, but still in the tens and close to 20. Drug-eluting stents came in, but then they are associated with problems of their own because you lose vasomotion. Okay, let me go to that. The they cause vascular inflammation. There may be problems associated with the metal, with the excipients that are added on or the polymers. It also leads to unequal drug distribution. The wider the stent struts go, the gap between the area into which the drug can penetrate also, there are wider areas where the drug does not penetrate. Then there can be occurrence of neoatherosclerosis. There has been a whole era of stent thrombosis, which is thankfully decreasing now. It also leads to an area where you cannot perform cabbage if it is needed. And very importantly, we lose vasomotion when we put in stents. And in many other cases, I still remember Dr. Renu Virmani showing cases where there was no endothelization in many of the stent layers, in patients on whom autopsies were done, necessitating long-term DAPT, which in itself is a huge topic. So that brings us to drug-coated balloons. There was an international consensus about 4 years ago, and the highlights of these were that the drug-eluting stents continue to have certain limitations that I just alluded to, and drug-coated balloons are a novel therapeutic uh, strategy in such a situation. And besides in-stent restenosis, they can also be used in native coronary artery disease. Uh, but as we go by, we shall realize that beyond the ISR, there are very, very niche areas where one tends to use drug-coated balloons with confidence. Although in the same breath, I'm saying there is evidence for every single subset of patients wherein the drug-coated balloons have been tried, and at least non-inferiorities have been shown. So the rationale, is just the opposite of drug-eluting stents. So it tells you that you leave nothing behind. because you're leaving nothing behind. There's no issue with vasomotion. There are no problems associated with future procedures or concomitant accesses to the side branches. Future procedures like coronary artery bypass. And there is a less chance of requirement for a prolonged dual antiplatelet therapy. Having said that, the only single important unequivocal indication for a drug-coated balloon is in-stent restenosis. It's a class 1 European Society recommendation. So post restenosis, post BMS or DES, class 1 ESC recommendation. The Italians also give a similar recommendation, but they also added 2A for small vessels, which are less than 2.75, some say less than 2.5, and treatment of bifurcation lesions. The German group and the Chinese expert group, they have similar recommendations. So three import from one, there are three areas where drug-coated balloons can be used. If we further go into the details, so as I said, there are three current major areas where they have been used and tried. Actually, they can be prospectively used anywhere, but on a very selected patients or very selected groups, particularly where you have extremely tortuous vessels. When the vessels are very large and the restenosis, chances of restenosis for say something which is a more than 3.5 or 4 vessel are less. It has also been tried in subsets like high bleeding risk patients and also been tried in acute coronary syndrome patients. So further down, there are potential applications in peripheral arterial disease. Um Interesting areas like using it to maintain the arteriovenous fistulas, the hemodialysis shunts. If they are going to restenose, then these have been used. For erectile dysfunction, it's a huge area and huge number of patients wherein it can be used. The As far as the drug-coated balloons themselves are concerned, for a very long period of time, the drug-coated balloons have been paclitaxel based. But then this has limitations because the if you don't add excipients to paclitaxel, the migration of the drug into the tissues is limited. With advancement in technologies, you have excipients, the paclitaxel does go through, but then it has been seen that beyond 30% of the drug that is coated, it does not get in, and majority of the thing goes down the bloodstream and is responsible for toxic effects. If we look In fact, in 2019, the US FDA has said that treatment of peripheral arterial disease with paclitaxel-coated balloons and stents is potentially associated with increased mortality. So there are certain issues with paclitaxel. So the technology required that we shift to sirolimus. We are all familiar with the limus based devices. We have been using them in the coronaries very effectively, and the problems associated with paclitaxel I have already highlighted. Further, why we need sirolimus? Because the mechanism of action of sirolimus and paclitaxel is different. Paclitaxel arrests the cells at a stage when they are about to divide. And so there are active pro-apoptotic mechanisms which can lead to eventually apoptotic cell death. And that is why the cytotoxic effects of paclitaxel are there. Comparing the two, we find that sirolimus-eluting drugs, sirolimus-eluting devices have a 10,000-fold safety margin. They have anti-restenotic and anti-inflammatory properties. But the problem with the limus drugs is that they have a slow tissue absorption and they have a short retention. What you actually need is that the drug in drug-coated balloon gets absorbed very rapidly. It should stay for a certain period of time, which was the property of paclitaxel. This also shows the typical curves. So what we find is that in drug-coated balloon, typically the concentration of the drug is extremely high, but when it starts high, it is on the border zone of the toxic effect zone of paclitaxel. Whereas the in sirolimus, this typical dose is far away from the toxic effect dose. So it was a need of the hour that sirolimus-based balloons come in. Further, as we see, there are the excipients also matter. If you see this slide, the paclitaxel-based stents are different if they use iopramide as an excipient versus if they use the other, you know, uh, chemicals as excipients, the BTHC that is highlighted here. So that is the change in technology that has been taking place. So from first generation drug coated balloons, which had a crystalline coating over the drugs, we shifted to non-crystalline coated or hybrid or amorphous coating of the drugs to the present time when we have nano encapsulation or microcrystalline coating. Now, what this has done is it has enabled drugs like sirolimus to be used. So, drug coated stents are now based on sirolimus also. And we have all the good points of a drug coated balloon minus the bad points of paclitaxel that are available. As far as the data is concerned, as I said, for a long period of time, it has been paclitaxel based. So this slide shows all the CE marked and FDA approved drug coated balloon devices which have been used in coronary artery. And needless to say, almost majority of them, large majority of them are actually paclitaxel based, and we have used them all. But there are a few which are sirolimus based now, and this perhaps is by and large the most exhaustive list that I have that I could lay my hands on of 5 different types of limus based drug coated balloons that are available. When we look at the trials, this actually talks of the different trials on ISR. So we have the options of balloon angioplasty alone, we have bare metal stents, we have brachytherapy, we have rotablation or cutting or scoring balloons, drug-eluting stents, and drug-coated balloons. So the blue trials are the drug-coated balloons. And what we see is that it is around the year 2010 that the trials with the drug-coated balloons started. This is a busy slide, but this also tells us what are the comparators. So this trial, for example, compared drug-coated balloons versus balloon angioplasty. And this DARE trial compared drug-coated balloons versus drug-eluting stents. So the data is small number of patients, but the comparators are so many. So you could actually compare it with a placebo. You could compare it with balloon angioplasty. You could compare it with having reimplanted, usually not a bare metal stent, or you know, comparing it with drug-eluting stents. So there are a number of trials which have been conducted in last 10 years. Majority of the trials which have compared drug-coated balloons and drug-eluting stents with balloon angioplasty have shown that both are better than plain balloon angioplasty in almost all the aspects. These are some more trials. There have also been efforts to improve the efficacy and learn how you can actually improve the efficacy of drug-coated balloons. So first thing is use intravascular imaging, because angiography alone never tells you the exact mechanism. It could be because of a poor stent expansion. It could be because of neointimal hyperplasia. It could be because of neoatherosclerosis. So imaging has to be used. Uh, Drug-coated balloons are particularly effective in patients who have neointimal hyperplasia, for example, wherein you use a cutting balloon. The second important thing to be noted is that once you have used the cutting balloon or you have dilated, the dissection that you get should not be flow limiting. And this, you should have prepared your vessel at least 0.8 is to 1 to the reference vessel before you use a drug-coated balloon. So it is not in all patients of ISR also that you will be able to use a drug-coated balloon, but this is by far the class 1 indication. This is a summary of, or the slide showing almost all the trials which have been done in de novo lesions, including small vessel diseases. So the pink ones are actually using the sirolimus the paclitaxel eluting stents. The blue ones are using sirolimus based stents, and the orange ones are the comparisons. So if we look at the small vessels, these are the 4 major trials which have tested and found that at least the target lesion failures or the late lumen loss with drug-coated balloons is comparable to the drug-eluting stents. As far as the in-stent restenosis is concerned, there are 2 analyses which are available overall. This is a 2020 based analysis of 10 trials, which looked, the 4 important things are primary efficacy endpoint, primary safety endpoint, net composite endpoint 1, and net composite endpoint 2. The primary efficacy endpoint was the target lesion revascularization. As we see, drug-eluting stents definitely do better than drug-coated balloons as far as the primary efficacy of target lesion revascularization is concerned. The primary safety endpoint is a composite of death, MI, target lesion thrombosis, and we find that the drug-coated balloons are better in this. But if you compare the net composite endpoints, they are no different between the 2 groups. So you have a greater safety with the drug-coated balloons, but you have a greater efficacy with the drug-eluting stents. This is another fairly large, but the total number of patients still end up with being about 912, which compared drug-eluting stents versus balloon angioplasty. This is actually yet to be published, and this actually shows that drug-eluting stent is superior uh, as compared to balloon angioplasty. And this slide I got from Concept Medical people. So for the sirolimus-based, drug-coated balloon, they have a huge amount of data of almost 9,000 patients, almost 10 completed studies. It's very difficult to go through each of the studies, so I just decided to take the summary slide of this. And there are so many trials. It is also said that no particular therapy, becomes very fondly acceptable unless it is approved in the US. The drug-coated balloons had not been approved in the US till March of this year, when this particular stent called the agent stent, which is a paclitaxel-coated stent, uh, this was the trial done for US FDA approval. It clearly showed that the target lesion failure was much less, statistically significantly less. It also showed that target lesion revascularization and target vessel MIs both were significantly less, and it was also associated with less chances of stent thrombosis. So based on this, the US has its first drug-coated balloon that is available and that is being used. Now, beyond the ISR, if we look at the other trial data, there are trials which have used drug-coated stents in large vessels, and this shows a meta-analysis, and they are almost equal. They don't show superiority, but they are non-inferior. The drug-coated balloons in the overall categorization, they are almost equal. If we compare in terms of target lesion revascularization, they are comparable, but the drug-eluting stents are slightly better in the larger vessels. If we compare these in different subsets of patients, in stable coronary artery disease, again, drug-coated balloons have been found to be non-inferior to paclitaxel drug-eluting stents. There are other trials like this one, wherein drug-coated balloons have been used in large vessels de novo in those patients who had high bleeding risk, and it was seen that the drug-coated balloons are better in terms of safety in these patients who have high bleeding risk. There are other analyses that are available, including this basket small analysis, which tested the tested the utility in vessels which were less than 2.5, that is small vessels versus large vessels. But again, no difference was found.
So,
As far as the
Dr. Sandeep,
bifurcation,
if you can, because it's better to have more discussion.
sure.
So if you can,
Another 2 minutes max. So in case of bifurcation, there is small data. This is a German consensus of bifurcation, which again talks of the same thing, that if you don't have a flow limiting dissection and you have a 0.8 is to 1 ratio, you could go ahead and give drug-coated balloons. Uh, small number of patients, but the important point is that the target lesion revascularization was very low. So they said that drug-eluting stents in the main branch should be used, but for the side branch, we can use drug-coated balloons. It makes sense if the lesion is involving the ostium and is extending to less than 5 millimeters beyond the ostium in a side branch. It is a very good case for a drug-coated balloon. But for the main branch, you continue to implant stents. It has also been used in subsets like myocardial infarction, and they are known to shorten the duration of DAPT in those patients. And this is again DEB-AMI, which is a trial of drug-eluting balloons in acute myocardial infarction. Again, there is a problem of thrombus interplay with the stent struts, and also there is always a chance of a vessel to stent size mismatch. These are two aspects which are taken care of if you use drug-coated balloons. In STEMI also, there has been a trial wherein a non-inferiority has been shown. And this is my concluding slide. Based on almost all the data that we understand that we have sirolimus-based coronary balloons that are available. And the three major indications where one can use these with confidence are instant restenosis, number one, small vessel diseases, treatment of bifurcation. Small vessels, particularly drug-coated balloons. I remember, Anil, the guys from the army showed several cases in 2008 to 2010 wherein there was a diffuse long lesion, there were diffuse long lesions. They would do POBA and leave the patients and they would do quite well. Instead of putting a whole metal jacket in a large right coronary artery or a very diffuse mid-distal LAD, putting in a metal jacket is a bad choice, and drug-coated balloons could be used here. Uh, Thank you very much, and I'll take questions.